Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 65th virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I am a personal trainer and the adult program coordinator at the NSYMCA in Northbrook, Illinois. This evening's presentation, entitled Myths and Misconceptions Around Bunions, is being recorded so that you will be able to revisit it again. Please feel free to tell your family and friends about it so that they too can view it once it is posted on the IBJI and NSYMCA websites. Also known as hallux valgus, bunions are foot deformities that occur when the big toe misaligns with the first metatarsal bone and bends towards the other toes. Bunions affect about 1/3 of adults in the United States and can lead to pain, difficulty wearing shoes, and mobility challenges. Many of us are influenced by common myths we hear about bunions from peers or on social media, but tonight, Illinois Bone and Joint Institute's Dr. Paul Goodman will debunk these misconceptions and talk us through the latest advancements in bunion treatment. Dr. Goodman is a board-certified podiatric foot and ankle surgeon. In addition, he is one of a limited number of surgeons board-certified in reconstructive rear foot and ankle surgery, plus he has a third board certification in wound care, giving him expertise to treat nearly all aspects of our feet. Dr. Goodman's specialty areas include reconstructive foot and ankle surgery, arthritis, trauma, deformity correction, arthroscopic surgery, total ankle joint replacements, and of course, bunions. He has been in practice since 2003 and currently works out of the Glenview and Wilmette IBJI offices. In addition to treating patients, Dr. Goodman is a nationally recognized lecturer and educator, often lecturing at conferences sponsored by his alma mater at the Civic Kern Hospital Residency Alumni Association. Dr. Goodman is actually a Northbrook native and graduated from Glenbrook North High School. He then received a BA from University of Kansas Lawrence, and despite having many physicians in the family and continually being told to become a doctor while growing up, upon graduating from college, he initially didn't want to become a doctor. Fortunately, however, after taking other jobs, he realized that becoming a doctor was his calling. It just kind of finds you, I think, he says, and at the end of the day, everybody has to love what they do. At least Dr. Goodman does, and we're thankful for that. His 5-star rating on Google reviews is a testament to his love of his calling. There were so many positive comments on Google that I had trouble choosing, but I landed on this one from Eleanor last August. Dr. Goodman is a wonderful doctor. He identified the source of my pain quickly and recommended treatment quickly. I wish that I had found him sooner. I've had this problem for some time. Dr. Goodman is highly skilled, knowledgeable, and professional. I am very grateful for his care. Dr. Goodman prides himself on tailoring to his patients' treatment plans to their individual needs, whether they are an athlete or just need to be able to get to the grocery store. He believes that every patient is unique, and he doesn't believe there is a one-size-fits-all scenario, even when discussing certain pathologies. He strives to find the accurate diagnosis for every patient and to create a treatment plan specific to each individual. Helping people is his reward. Dr. Goodman joined Illinois Bone and Joint Institute because he appreciated the holistic approach where everyone within his group works together as a team in a collegial environment and believes that together they can take care of anything. If you have foot pain, Dr. Goodman is a physician that will take the time to listen to you, and he and his team will do their best to treat you and get you back to the life you want to lead. During Dr. Goodman's presentation this evening, you might find that you have questions for him, which he will be happy to address at the end of the program. Simply type your questions into the question section on your screen, and I will receive them and relay them to Dr. Goodman immediately following his presentation. I do ask that you please keep your questions general, as he will not be able to address individual concerns without individual consultation. If you do have self-specific questions, please contact Dr. Goodman via one of the options that will be listed on the slide shown during the question and answer portion of the program at the end of his presentation. One last thing before I turn the evening over to Dr. Goodman. Please mark your calendar for our next IBJI and YMCA Education Series program. On Wednesday, August 20th at 7 p.m., Dr. Maj Tarabachi will discuss modernizing hip and knee replacements. Thank you again for joining us tonight, and thank you to Dr. Paul Goodman for your time and effort in putting together this program to address myths and expectations about bunions. Dr. Goodman, please take it from here.
Well, thank you, Karen. I feel like that wasn't even me they're talking about because it was too nice. I'm gonna enlarge this. And all right, so basically tonight we're gonna talk about myths and expectations about bunion surgery. And one of the biggest things that I want people to understand at the end of this is that there is no one size fits all. Bunion surgery is a very intimate relationship with you and your surgeon. And if you can't identify the proper procedure and understand the right recovery for you, it's going to be a failure no matter what happens, no matter how good it looks on an x-ray. So at the end of the day, it's really understanding the pathway to get from start to finish. So the things that we're going to talk about tonight: how we got the word bunion, what causes them, who should have bunion surgery or how they're treated in general, the different stages of bunions, all the different procedures performed, and this misconception of why bunion surgery sometimes doesn't work. So the first thing we're going to talk about is this origin of the word bunion. And it actually came from an 18th century term referring to a bunny or a bump on the top side of the foot. And while it looks like a bump, it's really not a bump that's there. The term hallux abducto-valgus is really three Latin words put together. Hallux meaning Latin for the big toe. Abduct means anything that moves from the midline. So if we look at our foot and we say the middle of the foot is the midline, then the big toe, the metatarsal bone, that the arrows are kind of the big arrow where it says looks like a bump, is pointing towards the head of the metatarsal. And that metatarsal moves away from the rest of the foot, and the toe rotates into what we call valgus. So if you put that together, you get this word hallux abducto-valgus. And on the outside of the foot, the pressure from those bones jetting out looks like a bump. Now, sometimes there actually is a bump. Sometimes it's nothing more than a spur. But this is a little different type of bunion, often called hallux rigidus, coming from an arthritic big toe joint. And this is not the deformity that we're going to be talking about today. Today, we're just talking about the hallux abducto-valgus, or the bone moving outwards. And this is a progressive problem. Its cause isn't your shoes, it's actually your genes. Not the genes we wear, but genetically our genes. It comes from inherited factors, and these factors lead you to developing a bunion over time. And these bunions are progressive deformities, which means that over time they worsen, but they don't worsen in a linear fashion. So when somebody has a bunion one day, it doesn't mean that tomorrow or next week or even a month or a year that the bunion is going to get worse. But something will eventually cause that to get worse. People look to environmental factors like high-heeled shoes, and maybe they do, maybe they don't. We haven't really proven what those factors are that lead to the exacerbation of bunions, but we certainly know that high-heeled shoes aren't going to make them feel better. So when we start to look at the evolution of treating these, conservative care always consisted of wide shoes. Why? Because it helps with pain. It doesn't necessarily take it away, but it helps it feel better. And that's what our goal is for any treatment, is to make this feel better. So deep shoes, orthotics, and a lot of times orthotics, they can be over the counter, they can be custom. It really matters on what shoes you're putting these orthotics in. If you're going to try and wear a dress shoe, I often shy away from full length orthotics and go to a 3/4 length orthotic. That's an orthotic that runs from the heel and stops right before the bunion. And what it does is it allows somebody to get a slightly bigger shoe and gives them more space in the toe box. And that extra space takes the pressure sometimes off of the bunion. Sometimes the pain is actually coming from inside the joint itself. And in those cases, medications will help. Those can be injections. They can be anti-inflammatory drugs, often referred to as NSAIDs, non-steroid anti-inflammatory drugs. And these can be oral medications like your Advils and your Aleve, but they can also be topical, things like Voltaren gel. But every once in a while, people will not get relief from conservative care. And in those cases, that's when we start to talk about surgery. Now, when we talk about surgery, there are lots of different procedures. There's commercials, there's things that you'll see online. There's nowadays direct to consumer marketing. And the most important part that we're going to talk about today, and possibly one of the biggest misconceptions that people have, is that all the procedures are the same. And at the end of the day, that's just not true. There's no dated procedure and some new procedure that came in. Most of the procedures that we're going to talk about, they've been around for a long time. And we'll look through the history of them and we'll see them come back at the end of things that we do today. What's evolved is really the equipment. So how do we decide which procedures to do? Well, our goal is always the same. We want to correct the problem. We want to have a predictable healing, and we want to minimize the chance that this will come back, because we already said this is a progressive deformity. And if it is, one day these bunions may come back, no matter which procedure we do, except for one that I really don't mention in here, which is a first metatarsal phalangeal joint fusion. Now, when we look at these bunions, there's different stages, or what we call severities. People's age might come into play, how strong or weak somebody's bone is. These are all different factors that your doctor needs to look at with you and figure out what the right procedure for the right stage and the right outcomes and expectations are going to be. And that's how we guide our treatment plans. So if you look at this, this is the different stages of a bunion. Here's one from the left. We see a mild bunion where just the bump is kind of projecting out and the toe's just beginning to lean over. And as we move from left to right, you can see that not only does that bunion stick way out, but the other toes have started to become influenced by the bunion. The pressure's moved to the central metatarsals or central rays underneath the second and third toe, and those toes start to pop up and almost cross over. And so sometimes we end up fixing a bunion even when the bunion isn't the pathology, but the other toes are. So we have to take into account how these things happen. And I always hear, like, is it better to fix it early so that this doesn't happen? Well, yeah, I guess it would be, especially because you're healthier when you're younger. But if it doesn't hurt, I'm very hesitant to want to break somebody's bone and go through the risk of healing on something that doesn't hurt yet. So I always say, if it isn't broke, don't fix it. But when it starts to hurt, no matter how mild or severe it is, we have things for you at every stage. When you start to talk about pediatric bunions, they're a little bit different, because the pediatric bunion usually starts as the toe leans over because the cartilage is off to the side. And it gives you this force pushing the bone back. And these you have to be a little bit more careful of because there's growth plates involved. So we want to kind of limit our procedures when the growth plates are open to procedures that don't affect the growth plate, with the understanding that possibly as an adult, they may need bunion surgery again. But the majority of people that we're going to see in bunion surgery, and I was looking at these facts a little earlier today, was that there are 350,000 bunion surgeries on average done every year. And we are also looking at the ratios. It seems to be about 80 to 20% women more than men. And I don't believe it's because the women wear bad shoes that they get the bunion. I think it's because the bad shoes hurt the bunion. And I'll never forget a comment that my residency director used to tell us, was that women's shoes were made by men who hate women. And I laugh a little bit about that, but sometimes it's true that these narrow shoes really put a lot of pressure on the bone, and that can cause a lot of discomfort. Another thing that people often talk about that influences sometimes our choices is this hypermobility, where the metatarsal, where you look at the X on the right side of the screen, that joint is called the tarsometatarsal joint. And sometimes that joint becomes excessively mobile, and that can lead to a bunion. But again, that fix is going to be a different fix than some of the other types of bunions that we're going to be looking at. So again, we're going to let these things dictate our choice of procedure. Sometimes it has to do with the rotation of the bone. If you think about 3 different ways that bones or our body moves, our body can move our joints in an up and down fashion. It can move it in a side to side manner, and things can move in a rotational plane that we call the frontal plane. And here on the left side, you can see that this bunion surgery was not a really big deviation between the bones, but if you look at those 2 little round circles, those red circles are circling 2 little bony circles. Those are called your sesamoid bones, and your sesamoid bones function like a kneecap underneath the big toe joint, and that kneecap needs to be underneath the big toe joint. You wouldn't want your kneecap on the side of your knee, so sometimes we have to rotate the bone, and in those cases you want to look at how can I rotate that bone and move it over, and the procedure on the left did that very nicely. The procedure on the right can also rotate the bone, but in this case the fixation wasn't as stable as they had hoped, and you can see that on the right side that screw eventually failed before the bone healed. And I would argue that it's more because of how this technique was employed, but I wanted to show it because stability matters. Ultimately, when this is all healed, we want a stable foot that you can walk on and not risk breaking. And this didn't break because of the type of procedure. It actually broke because of the inadequate fixation, but that's a different conversation. What we're looking at is just being able to rotate it and putting those sesamoid bones back where they belong. Now, when we start to look at all the different procedures, they can date back all the way to Carl Hutter, who discovered bunion surgery in 1870, and he was the first published reference to actually correcting what he called hallux valgus. So in the early 1800s, people were looking at this, and just like everything in life, nobody has the same TV that they had 20 or 30 years ago. Bunion surgery's evolved, but mainly it's the equipment that's evolved. And so when people start talking about a lot of the procedures that we're going to mention, the first procedures were named after a lot of the doctors that described the procedure. And then we've changed some of those names more recently to reflect equipment. And don't be fooled by equipment. This equipment is good equipment. We like these new shiny gadgets that we get to use in surgery that help people recover faster. But the procedures really haven't evolved that much. And when we talk about whether one procedure is better than another, it really comes down to what we're trying to accomplish for somebody's, again, age, stage, and bone strength. If those things aren't equal, then neither could the procedures be. So some of these procedures are better for one person and a different procedure better for somebody else. And that's what we're going to start to look at. So one of the first procedures that we're going to talk about is this Reardon bunionectomy or osteotomy. An osteotomy refers to breaking the bone and moving it into a different place. Now, it's important to remember that when these procedures were first designed, we didn't have screws and staples and plates. So at the early stages, they had to look for ways to make these stable where you could heal just like a fracture by putting it in a cast. And what Reardon tried to do is redirect the cartilage surface of the bone. And it's a good procedure even today for certain types of deformities. Keller had revised a previous described bunion from Davies and Colley where he just removed the shaded areas of the bone on the right. And he was able to just put the toe where he wanted and sew it in place and didn't care about letting bone heal because the bone was gone. And it works. And that's still used today for sometimes an elderly patient that doesn't have good bone stock and the bone is sticking out. Maybe they're getting wounds and we just have to do something. And sometimes that Keller bunionectomy is even done with spacers to try and mitigate some of the shortening that happens over time because the bone is missing. But then you had these guys, Silver and McBride on the left, and these guys really stepped up their game a little bit. They realized that they could shave off just the side of the bone. And I see a lot of different deviations of this in today's version of bunions, especially mild bunions, when people say, oh, my doctor got me back into my shoes in 2 weeks and I didn't have to do any kind of recovery, it's probably because the bunion was kind of mild and you could get away with doing these simple procedures. But again, I always caution people, when you do these, you have to remember this is still a progressive deformity. So what changed from Silver to McBride was that McBride tried to remove one of those sesamoid bones and sew the soft tissues across from the toe to the metatarsal to try and prevent the recurrence. So now we're starting to look at the first time where somebody said, I want to try and stop these things from coming back. Did it work? It didn't. They still came back, but it was a little evolution to the bunion surgery. Dr. Aiken did something a little different in between these guys. He thought, what if I break the toe bone itself and take a wedge out? And that's what you see on the right, taking a little wedge out called an Aiken osteotomy. And then people fixed it all different ways. They sutured it in the old days. Nowadays, a lot of people put staples or screws or pins. And again, fixation is really the surgeon's choice. It's whatever they're the most comfortable with using. There's not one right answer on how to put the bone together. We just want the bone to heal. And the Aiken osteotomy is still used, and we'll see it today in some of our other cases later. By 1926, Meyer described a Z osteotomy, and this later became known as the scarf bunionectomy. And the scarf bunionectomy, again, a bunion that is used still today. Back then, we used these Z cuts because they didn't have screws, and they were looking for a carpenter's way to move the bones across, slide and correct the bunion in a stable fashion where the bone wouldn't just fall apart on its own. And that's where the scarf was invented. In a little bit before that, you had Homan, who noticed the idea of trying to rotate the bone. And Homan would just cut straight across and then impact the bone onto itself. And if you look, he had this little tiny shelf that he used to kind of impact the bone on. He sometimes would cut that little extra part to push the bone together because, again, we didn't have screws. And this looks a lot like that bunion that we looked at where the screw broke. Very similar technique used today in what we call MIS, or minimal incision surgery bunions. So that's basically a Homan, but we have better fixation now. Albright had a little different idea that was really popularized in 1934 by a guy named Lapidus. And Lapidus went after this hypermobility thought of this joint. And what they basically did is they took out a wedge of bone at the joint and fused the joint together. And this was able to rotate, close the bone down, and fuse the joint so that the bunion, in theory, wouldn't come back. I can tell you that there's no such thing as never coming back. I don't care what procedure people have. Unless you fuse the big toe joint by those sesamoids, there's a chance that these things come back. But this is a very stable, very rigid, and very thorough correction. But it does require a lot more healing than some of the other procedures. A lot of the modern bunions end up using a combination of techniques. They shape where they did kind of a modified McBride or a Silver. They didn't take out the sesamoid, so it's probably more of a Silver than a modified McBride actually. And then they did that little wedge in the toe where we call an Aiken, and these were fixed with screws. And you can see that the toes end up very straight, and people are generally very happy with this. So this is a combination of using procedures done from years ago with modern hardware. And these are just two different devices that we used. So here again, we're looking at a modern bunion done with a minimal incision approach. And these are two different systems, both looking at a minimal incision bunionectomy. And this is why I say that last one might not have been so great that I showed the example of for the stability, because in reality, we should always have two screws across it on the left, or one of these newer plates that you can see on the right. And again, it's not one better than the other. These are surgeon choice. These all work. It's a matter of selecting the right patient who has the right bone stock or health to the bone, and looking at what the patient's expectations are going to be afterwards. A lot of these newer procedures are really just packaged into equipment. All of these Lapalock, Lapifuse, Lapiplasty, these are Lapidus bunionectomies with different kits to do them, and they all work. What ends up happening, unfortunately, is that a lot of the advertising goes directly to the consumer, which is the patient, and then they walk in and say, I want to have procedure X. I want a Lapalock. I want a Lapiplasty. I want a Lapifuse. And the reality is that those are all the same. They're just different hardware. And what you really want is the Lapidus bunionectomy, and that might not be the bunion that you actually need. So the different equipment and different instrumentation does have some of an effect on how long somebody is off their foot, because some of these devices and newer techniques tend to give you more stability during the healing phase, but it still takes bone 2 to 3 months to start to heal. And if you expect your bunion to be done faster than that, no matter what the promise of these equipment companies will tell you, I will tell you, you are going to be disappointed. It takes time to heal. So what's the difference? The difference really becomes cost, and some of the newer technologies really have changed what we do. If you look at plates, plates alone have become new in the sense that we can now lock screws into the plate. The screws themselves are different. We now don't have to drill and over drill and do all these different techniques to put a screw in. We can put little pins in and the screws go right over them. We have staples made out of all different metals that compress all different ways. So when we start to look at this, we can see that the technology is important. I'm not saying that all this new stuff, ignore it. The old conventional plates, if you look on the left here, these screws, if you look at the head of the screw where the circle is, they don't have threads in it. And so the screw would just sit on top of the plate, which means the screws could toggle. And they only allow the strength to be matched by the strength of the bone. Whereas the locking plates, which are on the right, those purple to blue screws, they actually have threads in the screw, and those go into threads in the plate so that the screw goes in at one angle and it stays there so that the bone can't move. And while that might be indicated for some people, especially people that have softer bone, it actually might be detrimental for other types of people. So it really matters to match the type of plate and screw to the strength of your bone and how long you're going to be on or off your foot. And again, this is something that your surgeon needs to discuss with you, not something that you should pick up from an advertisement. The same thing in different types of screws. At one point, it was believed that solid screws were just going to be better. And over the years, we've studied this over and over, and it just isn't true. All these screws work, and they all work well. Some of these screws have tips that can drill, so it saves time and less thermal damage to the bone. So it's really neat how far along we've come with screws and plates, all these things, even the staples. This is the example of a headed and a headless screw. And sometimes you put a headed screw on to get compression from the head. Sometimes these little threads at the top of the screw can thread into the bone and offer compression that way. Sometimes you put washers on screws to compress on different angles. These are all different things that we can do. Staples, instead of just compressing in the tines are the legs that come down. Sometimes the whole staple can bend and you get compression across the bridge. These are newer techniques, different advantages, and used for different indications. So again, how you're going to pick what you're going to do is got to be based on your bone health, the strength of the bone, and where the location that it's going to be inserted. All of these things work. And in reality, sometimes if it's equivalent, if you're going to have no better outcome with one versus the other, especially 6 weeks from now, sometimes the old-fashioned stuff works well and saves you some money. Everything can work. It's just a matter of picking the right procedure. The other myth that people often have is that they can't have metal in their body. And while some people will have true metal allergies, and these things can be detected beforehand with metal testing by immunologists, the reality is that most of this hardware that's in there is inert. It's not going to cause a lot of irritation and reaction. Sometimes it does take a little bit of time to get used to the equipment, but over time you do, and it rarely needs to come out unless it bothers you. And the ways it usually bothers people is that you feel it under the skin. It becomes prominent. And in those cases, yes, we can remove it. And once it's removed, as long as the bone is healed, you do not have to be off of your foot all over again. But no matter what we use, it's still biology, and bone will take a minimum 6 to 8 weeks before you're going to be able to really put full weight on a lot of these procedures. In fact, some of the things that affect healing the most is bone health. And unfortunately, we live in a climate where a lot of people are vitamin D deficient. So we want to see people getting their vitamin D. The dermatologists don't like this, but the reality is the best vitamin D still comes from the sun. I'm not saying go put the sun oil on and get the old tin foil out to reflect it into our faces anymore, but a little bit of sun without sunblock can really help our bones. Just be careful and make sure your dermatologist is okay. They usually say 15 minutes a day, no more. Medications can affect bone healing. People that are on things such as steroids or some of these biologics for rheumatologic conditions or skin conditions, they can slow down our healing. Smoking can slow down our healing. And one of the biggest problems with smoking isn't just that you're destroying your lungs, it's that the carbon monoxide from the smoke will displace the oxygen, and we need oxygen for wound and bone health. Our overall health can have effects. Things like diabetes or poor circulation, those are no-nos. We got to be really careful with people that have underlying health issues. And I would say if you started to survey surgeons who operate in the foot, one of the biggest factors that affects healing, compliance. Every procedure is a little different. You have to follow your doctor's instructions. If they tell you not to walk on it, don't walk on it. If they tell you it's okay or that you need to walk on it, walk on it. Don't change your bandages unless the doctor tells you so. Don't get them wet unless they tell you it's okay. These are all things that you need to discuss with your surgeon to make sure that you're following the proper instructions. No surgery is ever without risk. So I'm not going to say that bunion surgery is a home run every time. Some people do have a delay or lack of healing. Sometimes the bunion gets undercorrected or overcorrected. Some people get infections. Sometimes it does lead to stiff joints, but I think that stiff joints are usually more a complication of scar tissue, which can be rectified with physical therapy, or sometimes just the wrong procedure. Some people get prolonged pain. I don't know why. There are people that will sometimes just have pain in the area. And areas of numbness is not uncommon because there's a lot of small little nerves that some people have that will get damaged in surgery. But overall, bunion surgery has a really high satisfaction rate. When people say, I was always told not to have surgery on my foot, that's really not true. What you want to make sure that you're seeing is a surgeon who is well trained, whether they're podiatry or orthopedics. You want your surgeon to be board certified or at least in the board certification process for surgery. And afterwards, you should be able to get back into all types of shoes. I know that we don't really love people wearing high heels, but if that's your jam, you should be able to get back into a high-heeled shoe even after surgery. People always ask me, will they be able to run or play sports again? And the answer is, what are you doing this for if not to get back to the activities that you want to do? So when we start to look at some of these examples, you'll start to see that here's one that we didn't have to really take the bump. We just rotated the bone back in and we did just a lapidus bunionectomy. Didn't touch the toe at all. Everything looks like it's back together. And in this case, we used 2 of the newer staples. Here's another one. Again, 2 staples, same thing. But this one, we put a screw across because there looked like there might be some mobility between the first ray and the second ray. So we put that screw across to stop that. Maybe we're preventing recurrence. I don't know, but it still didn't touch the big toe joint at all. Here's one where we just did what we call that modified chevron or scarf, where we made a V cut in the bone and we just slid it over. Again, the alignment looks the same as if we had done one of those other joint fusions, but this is going to be a quicker healing and possibly less debilitating down the road. The only downside is maybe a higher incidence of recurrence. And again, I can't tell you that by fact. It's just a theory that if you fuse the joint below, maybe it'll be harder for that bunion to come back. Here's one where we did, again, that lapidus bunionectomy. We used a U-shaped locking plate this time instead of staples. And here we did an achid with it to make sure that the toe straightened out. This is another one where we just did that long-armed bunion. It's kind of a modified, not a Z cut, but this one's more of a V cut. And again, we have very nice correction. But what I want to point out about this one is that you see those screws in the bone next to it. Sometimes when we do these procedures, it leaves the bone next to it a little bit longer. And you have to kind of improve the length of all of the bones so that they make better contact, so that we don't have a new problem developing there. Things like metatarsalgia, plantar plate tears, hammer toes develop, metatarsal stress fractures. So in this case, we did the bunion, but we also had to shorten the second metatarsal. Here's another one where we did that same type of chevron, but in this case, we did it with an achid. And again, we have headless screws so that it can be sunk right into the bone. This is another one where we did that lapidus bunion. Again, we used the 2 staples, but here we did shave part of the head down. And we did that because the head still felt prominent and we were worried it was going to rub in a shoe. Here's another one where we just did the lapidus, but again with one of the U plates. And again, because that second metatarsal was a little long, we shortened the metatarsal. These are all things that we're looking at in trying to come up with our plan beforehand to prevent problems in the future. This one, no hardware. There's no hardware because all we had to do was really more of a silver where we just shaved the bone down. We didn't have to take the sesamoid out. We shave it down, we tighten the joint capsule. Patient did great. Again, I can't tell you if this bunion will come back and if so, when, but we haven't burned any bridges. And this was a very fast recovery because you're not waiting for bone to heal. Here again, just a chevron, which is that V-cut osteotomy in the bone and 2 screws. Here again, we used 2 different plates, different way of fixing it. These are what we call biplanar locking plates. One plate's on top, one plate's on the side. These are locking plates, very strong fixation. And this one we did go in and shave down the side so that that bump wouldn't be bothering anybody in a shoe. So the bottom line is that it's okay to do your research. We want patients to be informed. The more informed a patient is, the better results you're going to have. But there's a lot of ways to get a good result. And it's not that one procedure is better than another. It's a matter of listening to your doctor, looking at the stage of the bunion, picking the procedure for your bone stock, your overall bone health, picking a procedure based on the severity of your bunion, your expectations and age. And as much as we all want to say, my neighbor had this one done and I want this, or I want it to be the same, she had a great result, everybody's unique. And that's the bottom line, and the biggest thing that I want people to take home from this lecture is that the most important part to selecting bunion surgery is that consultation with you and your physician, where you take x-rays, where you look at what your activity level is, how long do you have to recover, how is it going to impact your life, which products would be matched to that procedure that is going to be the best for you, not which procedure you read about online. That's all I got. Hopefully that gives us enough time for question and answers.
Yep, it sure does. Thank you very much, Dr. Goodman. Very interesting. Thank you for putting it in lay terms for us as well. All right, so I have an interesting question. How do you determine the health of the bone? You mentioned the things that cause bones to have poor health, but how do you determine the health of the bone?
Sure. So sometimes we know in advance. Somebody might come in and say, I'm already seeing a doctor for my osteoporosis and I take this medication. But sometimes we can't. And when we look at an x-ray, there are certain telltale signs in the foot that we can look at and say, maybe this bone is a little bit weaker than I think. One of them is looking at something called the medullary bone to the cortical bone ratio of the second metatarsal. So we look at the bone next to the bunion and say, how much of the shell of the bone or the cortex do we have to the medullary bone or the central part of the bone? And if the cortex starts to look thin and the central part of the bone starts to get too big, we start to worry that the bones might be a little bit weak. And then we might order things like a bone metabolism workup, send you to either a rheumatologist or a bone specialist and have them evaluate you. It's always nice when somebody comes in with a DEXA scan and says, yeah, my bones are healthy, but that doesn't really happen in the real world that often.
Got it. Okay. Okay. So with regard to osteoporosis, someone's asking if they have osteoporosis, should they have reclassed before bunion surgery?
So I always say when we start to get into some of the osteoporosis drugs, there's a lot of different classes of drugs. Some of them help build bone, some of them stop bone from going away, and some of them help mineralize bone. And everybody needs different treatments based on which stage of osteoporosis and the type of osteoporosis somebody has. And that's usually somebody who's going to be seeing either an endocrinologist, a primary care doctor, or a rheumatologist, somebody that really specializes in bone health. And what we would do is work with them. Your surgeon should always work with those doctors to find out where the optimal time is. We would always love your bones to be as healthy as possible, but sometimes it's not realistic. When somebody's in a lot of pain and we're just at a point where we're going to go forward, we just have to do it in the safest way and pick the procedure based on that.
Speaking of that, do you know before surgery exactly what procedure you'll be doing, or do you figure it out sort of once you get in there?
I think most of the time we have a really good idea of which procedure is going to be the best for you. And we do that by examining the foot and looking at how mobile the joints are, how stiff or mobile they are, and based on x-ray angles. And we kind of have this idea. Now, sometimes we get in there and we get, like a lot of those times, we get the first part of the bunion done, whether it's a lapidus, a scarf, a chevron, and then we realize the toe didn't want to cooperate as well as we think. And then we start to add some of the other procedures to it. But that usually we know in advance as well, like, there's a good chance you might need this. If not, great. But if you do, we're just going to make sure you're prepared.
Great, thank you, awesome. Okay, we're going to back up a little bit. With regard to a mild bunion, are there exercises that can help with those?
I wish there were. And there's a lot of splints and devices that people sell that I've seen people come in with their bunion contraptions that push the toe over and they've been sleeping in it every night. And I've never seen one work. the reality of it is that you're just seeking pain control until the day comes where you throw in the towel.
Okay, great, thank you. And so that includes toe separators and all those kinds of things.
Yeah, I mean,
got
they
it.
certainly make people feel better. So a lot of times if your big complaint is that your toe rubs the toe next to it, and this isn't an uncommon complaint, where it starts to form sometimes a callus between the toes or skin irritation, using a toe separator is a fantastic option until it isn't. You know, eventually, even the toe separator, sometimes that starts to hurt, or it doesn't stay in place, starts to irritate the skin itself. So as long as it's working, use it.
Great, that makes sense. Okay, super. So that answers that question. By the way, there's a bunch of thank yous on here. Okay. You mentioned that a bunion is not the same as the hallux rigidus. And a few people have asked me, you know, I don't want you to have to go into it now, but I want to kind of put it out there as a thought of a future webinar for us to do. Do you see a lot of that in your practice? A lot of people with hallux rigidus compared to bunions?
Yeah, I would probably say that I almost see an equal amount.
All right.
It's very common.
All right, so that's something we need to talk to our IBJI folks. Maybe we need one of those.
Yes.
We can have Dr. Goodman come back. Super. Okay, thank you. All right. Someone's asking me if I don't remember you discussing the Schuyler procedure. Is that a different procedure?
So I don't think it's the Schuyler. I think it's the Sklar bunionectomy.
That could
And
be.
and that's just, you know, again, we're talking about generally a marketing
Got it.
type of bunion done by a doctor in the area who has come up with his own technique of how he puts his screws in and how he's breaking your bone. But again, you're just looking at his technique of doing one of these bunion surgeries.
Got it. So it was his marketing and it's not a different procedure. Okay, thank you. And sorry, it did say Schuyler, but I'm sure you're right about the Sklar.
And it is, you know, I'm sure he has a variation of how he's modified one of these other techniques his way. I can't speak to that, you know, what he's doing in the OR, but that's what you're really looking at here.
Yeah, got it. Thank you. Okay. Is there ever a time when removal of the fat pad under the MTP joint should be removed, and what functional impairments might result?
Well, I can tell you that I've never removed the fat pad underneath the big toe joint. I could see it if somebody had a very prominent, let's say they had a rheumatoid foot with a really high arch and there was really excessive cushion down there, that you wanted to minimize it so that the patient's toe would reach the ground better. But that is very rare. I would think that you would want to keep as much cushion underneath there as possible, because down the road, we all get a little fat pad atrophy. The cushion underneath the ball of the foot starts to kind of fade away. And as that happens, the bone becomes a little bit more irritating on the bottom of the foot, and you might start to see calluses and things start to form down there. So I'd be very reluctant to ever do that other than extenuating circumstances.
Great, thank you. Okay. And do you often fix a hammer toe in conjunction with the bunion surgery? Is that second one you're talking about?
Yeah, as the bunions progress, a lot of times people will end up developing a hammer toe. Again, the same biomechanical problems that are leading to the bunion start to cause overloading at the second toe. And so if they have a hammer toe, I would certainly correct it at the same time, because it really, now that you have the bunion corrected, you have space to put the toe back. It's the other question I'm going to jump in is that when somebody just wants their hammer toe done and they have a bunion, that's a terrible idea. Because if you don't fix the bunion, you generally don't get room to put the hammer toe back. And people are generally very disappointed in the hammer toe surgery because the bunion is still there.
Got it. Okay, thank you. That makes a lot of sense. All right. Someone's asking, is a boot required for the full 6 to 8 week bone healing process?
So again, it kind of depends on your bone strength and what procedure you had done and what your doctor feels comfortable with. When I'm breaking somebody's bone or I'm looking at these things as an unstable osteotomy or fusion, I generally will keep people in a boot for about 6 to 8 weeks. It's just kind of been my safety net. I always say you're never going to run into trouble by being too cautious.
Fair enough. And this person must have come on a little bit late because she asks, how do I know when it's time to consider surgery? Is it better to do it early or wait until it's making a big impact on my quality of life? For those who came on late, would you mind just repeating your answer to that real quick?
So there's never a stage of bunion that's right or wrong. We really look at it as, when does it really hurt? If it's impacting somebody's activities, they've tried things like anti-inflammatories and wider shoes, and they're not making progress, and it is bothering you to the point where you say, I would love to go work out, but I just can't because my foot hurts. Or I would love to go on a walk or wear these shoes, but I just can't. And I'm talking about reasonable shoes.
Sure.
Then you start to think about, this is probably the time to do it. And that can happen. I can show you people with really, really, really severe bunions, and they come in to see me and I think they're here for a bunion. And they're like, well, that doesn't hurt. And I can show you people that come in with really mild bunion, and I think they're there for something else. They're like, oh, are you going to talk about my bunion? It's killing me.
Okay.
And so it really is about pain. And it's not that one person's weak and the other person's strong. There's a lot of things that can cause pain, whether the bump is rubbing against a nerve, whether there's more arthritis in the joint or not. There's a lot of different ramifications to having a bunion. So when it starts to hurt enough, fix your bunion.
Fair enough. Great. And a bunch of questions are coming in like that. So I'm trying to kind of scroll through and see which ones. Okay. Oh, someone asks, are these procedures usually covered by insurance?
They are. There is for certain insurances, there is a pre-certification process, and that's what most doctors are going to go through. Their office is going to submit your x-rays and their exam notes and get it certified so that you should know beforehand that it's covered or not.
Great, thank you. Okay, good to know. Is it a 6 to 8 week wait for driving after a right foot bunion surgery?
It's a great question. And so what I tell people is this: if the procedure that I did is stable, I will let you drive after 2 to 3 weeks, provided you meet this really important criteria. If you had to jam on the brakes because something came out in front of you, I don't want you to go, ouch, and pull your foot off the brake. And that takes sometimes longer than people think. But
Okay.
if you're not out of pain and you can't hit the brake hard without either ruining your surgery or causing pain, it's not the right time to drive.
Got it. Okay, good to know. That's very fair. All right, how long does the surgery itself take typically?
Most of these procedures take anywhere between 40 minutes to an hour. They're
Okay.
usually done outpatient, and most of these things can be done under what we call twilight or IV sedation, very similar to a colonoscopy or wisdom teeth.
Oh, interesting. Okay, good to know. All right. And so they're typically outpatient procedures?
They are.
Excellent. Okay. To clarify, someone says, bunions cannot be prevented?
I've never seen anything in any of the literature that I've looked at to prevent bunions. And to that, I haven't seen anything that really stops recurrence either. There's a lot of theories on it. If we correct this, then it won't come back. If you do it that way, it won't come back. But they've all been theories, and I can show you bunions that have come in that they've had bunion surgery done all over, and they come back and they come in and I said, wow, I'd love to see your x-rays from when this was done. And it looked fantastic when it was done and not so much now. So they can.
And do you think it's a genetic thing? Is that like some people don't have any bunion issues and other people have all kinds of foot issues?
It almost always is a genetic thing. If you look, it might not be mom or dad. It might be aunt or uncle or grandma or grandpa but somebody probably had it.
Okay. All right. Another interesting question. Where is the incision? Top, bottom, side?
So there's two locations that people use regularly. One of them is on top of the joint, and the other one is on the side of the joint. I lately have, for the last probably 10 years, been using one on the side of the joint just because I feel like when you look down at the foot, it doesn't show as much of a scar.
Okay.
But it's not to say that one is any better or worse than the other.
Okay. And how invasive are those incisions? Are they?
They're invasive. Bone surgery is bone surgery.
Yeah.
And the one thing that people always kind of gloss over is they think that because it's a small bone, it's not going to hurt that much.
Mm.
And I always tell people, prepare for pain. If we get you through with little pain, great. But when they study pain medicines, they often study them on bunion surgery. So, it's not a nothing surgery. So plan for recovery, but at the same time, that's why we have fantastic medicines for this nowadays. We can even send people for pain consults. For people that have trouble with pain medicine, we sometimes will send them for pain consults, and they can do genetic profiling for which pain medicines work the best. So it's really advanced when we start to talk about how do we handle people's pain as well.
That's cool. And you work with your patients to help them figure that out.
Yeah, and we work really closely with our pain team here.
Great, great. And you mentioned a tiny bit about physical therapy after surgery. Can you go into that a little bit more?
Most people actually don't need physical therapy after bunion surgery unless they start to get a stiff joint. Now, there are times where we tell people you got to start wiggling your toe or it's going to get stiff, and we know that it's just a little bit too uncomfortable. And so as the toe gets stiff, we know, all right, we're going to probably need some physical therapy to get our range of motion back at the big toe joint, but we generally won't do it until the bone is solid enough that when we start stretching the joint, we don't endanger our bone work.
Okay, great, thank you. All right, when a significant bunion and hammer toe are present, can this result in clawing of the third and fourth toe?
It can. Over time, the advantage that the tendon has over the other, so you have tendons on the top and the bottom of the foot. And when the tendons on the bottom or top of the foot start to become stronger than its counterpart, the toes will start to hammer and claw. So as one of them starts to go, sometimes the advantage happens to the next and the next and the next. So we definitely will see that over time. And it just means more work for us when people wait longer, but it shouldn't. Trying to stop those things in advance, if it doesn't hurt, let it go until it does.
Got it. Okay, okay, that makes sense. Someone's asking, do you treat Medicare patients?
Yes.
Great. And let's see. Boy, so many thank yous. It's great. Thank you. Lots and lots of thank yous. Okay. These are questions you've already answered that came in before you answered them. We already did that one. We talked about physical therapy. People are asking, can you walk with the boot? You mentioned being non-weight bearing.
Yeah, so I usually tell people for the first couple days for sure, take it easy. And then you can start walking generally for most of these procedures on the heel of the boot. And as the bone starts to increase in healing and strength, you can start to load more and more weight on that foot. But again, this is followed very carefully over time with x-rays and pain, and your doctor actually looking and feeling the stability of what he's done or she's done.
Okay, got it. Okay, one last question. I'm guessing after you just said that, you probably don't recommend doing both feet at once?
There are some people that will. I generally do not like it. I think you really do a better job having one good foot to get around.
Great. All right. It's 8 o'clock. Thank you very much, Dr. Goodman. Thank you, everyone, for joining us tonight. Fabulous presentation. And remember, if you need to reach out to Dr. Goodman, there's information on the screen. You can take a quick picture of it. And you can also find this later if you want to watch it again on the IBJI and NSYMC websites. Have a great evening, Dr. Goodman. Have a great evening, everybody.
Thank you all.
Thank you. Bye-bye now.
Thanks.